Okay, so we will start. So we have some bacterial species that we never had a chance to talk about. We're going to talk about those. They're pretty exciting. And we're going to start up front with species of Listeria, and specifically Listerium inositogenes. It's the microorganism that is a very common cause of bacterial gastroenteritis and neonatal meningitis. Okay, so it's the psychotrophic microorganism, meaning that it can reproduce, although slowly, at the cold temperature, something like 37, 40 Fahrenheit, meaning it can grow in the refrigerator. And it's a very common cause of the food spoilage. In order to get rid of Listeria, we actually pasteurize various foods. It's pretty commonly transmitted through the raw, untreated milk or eggs or any kind of poultry products. Now, since it causes gastroenteritis in adults it is usually mild. It's self-limiting, usually does not require any treatment. But in neonates, accidental transmission of Listeria into the vaginal canal may lead to the neonatal meningitis, which also is pretty common in generally immunocompromised patients. Now, this map shows you the distribution of Listeria incidence in the United States. It's fairly low, and you can see that it majorly is associated with heavily populated urban areas like New England or Pacific Northwest. But what I find interesting, so Listeria is a huge problem for food preparation industry, like restaurants, cafe bars. If you can imagine that, if there is a listerial contamination of the surface, you have to clean it. When people cook poultry restaurants, they have to clean it. And Listeria for a long time was one of the main scourges that plagued the food prep industry. So using conventional chemicals in the areas where surfaces are in contact with the food can be, inconvenient, because if you're using, say, a chlorine bleach, you need to, clean the surface of that bleach and so on and so forth. So the interesting approach was developed to control Listeria on the food prep services and in the food. It is phage-mediated approach. We mentioned before that bacteria can be infected with phages. Remember that conversation, right? It's viruses of bacteria that can kill them. So the special spray was introduced which contained lytic phages capable of infecting Listeria. So these graphs show you the survival of Listeria with and without use of the phage, without any, so these lines, the top lines, represent the growth curve for survival of Listeria in the food without phage treatment, and the bottom lines, like these ones, with the phage treatment. So you can see that in some foods, this phage is quite effective. For instance, if you spray the phage on the iceberg lettuce, it significantly reduces the Listeria load on it. Okay, same goes for cabbage, chocolate milk, cheese. It is for some reason not effective on things like smoked salmon or turkey breast. So there's probably something to various foods that either prevents the phage infection or absorbs phage, something else happens to it. But the sort of take-home messages, phage therapy, in this case, or should I say not therapy, but phage control methods, are effective, safe, and in fact that spray was approved by FDA and can be used and is used in the restaurants. They basically spray it on the surfaces and, just can live there and you don't have to remove it. You know what I'm talking about? If it gets on the food, it's safe. So people can basically eat it. Now, Mycobacterium leprae here is one of the examples of MYCOBACTERIACEE. We talked about tuberculosis. This is the causative agent of leprosy. So it's a typical mycobacterium, gram-positive with mycolic acid outside, which actually renders it insensitive to gram staining. So Mycobacterium leprae has to be stained with the acid fast stain. It was discovered by, I believe, a German guy named Hansen. So sometimes it is referred to as Hansen's bacillus. So, just like Mycobacterium tuberculosis, it infects macrophages and forms tuberculomas or granulomas. So this form of leprosy is called tuberculoid form. Now this is more self-limiting sort of form, more benign. I mean, it is disfiguring, but patients with this form, usually you can find multiple granulomas in different tissues, but it does not affect the tissue function or tissue structure that much. However, in lepromatous form of leprosy, shown here, the cytotoxicity, the response from a patient's own immune system, leads to the tissue destruction, which is rather painless because along with the connective tissue, the nerves are being destroyed, so patients do not really feel pain in, for instance, this in the fingers that that they lost. So this is the distribution of the leprosy in the world, and I'll give you an idea that yellow is not reported. I can tell you there's nothing to report in these countries. There's no leprosy there, and then it goes from light blue all the way to green. Green being the most, the highest number, total number of cases. Now we have to understand that prevalence, the number of people infected, okay, and number of new cases, incidence, two different parameters. We talked about it. Does that make sense? So if you would look at this map, you will see that two countries that have the highest number of people with leprosy, Brazil and India. Yes. Yes. And thank you for reminding. I'll address it in a second. Okay. So Brazil and India have the highest number of people that are infected. But, for instance, Brazil actually significantly reduced the incidence of leprosy. So they reduced the number of new cases. Because people with old cases, they keep on living, They still have leprosy, keep on living. So this graph shows you the distribution of leprosy cases over the year. You can see that, WHO efforts to reduce the number of infected people actually fruitful, We reduced the number of leprosy worldwide. As Jacob asked, so there are several routes of transmission. There's contact. There's respiratory. Now, leprosy is fairly poorly transmitted, meaning that you need a prolonged close contact between infected and uninfected persons, say living in the same house. Does that make sense? If you just talk to someone, you're not going to get leprosy. The natural reservoirs for leprosy are armadillos, so you technically can acquire it. If you ever got encountered an armadillo you know, that catch it is almost impossible. They really sneak in really fast. So only if it's a roadkill. Then in the United States, the only way you can actually get in contact with armadillo if it's a roadkill. Now, bless you. Now, leprosy is fairly easily treated, okay, with the dapsone, sulfamethoxazole, trimethoprim. Now, one more thing about leprosy that actually is quite interesting, I think, were efforts of the United States government to quarantine folks with leprosy, which were pretty common in newly acquired Hawaiian Islands. If you've heard about the island of Molokai, that was the quarantine facility, the government quarantine facility part of the Hawaiian archipelago. The idea was to send all people with leprosy to Molokai, which will prevent the transmission in the general population. That program was not voluntary. So basically people with leprosy were caught, sent to Molokai, and were left there to die because there was no treatment at the time. And recently, well, I don't remember the exact date, but American government actually acknowledged that it was inhumane and, you know, against the law, and they paid compensations to not whomever survived, because I don't think anyone survived, but the descendants of the folks who were sent to Molokai. Now, a couple more microorganisms. They belong to different orders, actually. Nocardia and Crenibacterium. So Nocardia, specifically Nocardia astroides, is a pretty common cause of pneumonia in hospital settings and immunocompromised patients. Okay. So here in this image, Nocardia is shown growing in the center. It's the yellow colony. It's also acid-fast microorganism. So it's technically gram-positive. Does that make sense? It is gram-positive, but it has a mycolic acid, which makes it stainable only by acid-fast staining. Why I mention it, it's not a terrible scourge, but it's a pretty common cause of pneumonia and endocarditis in the hospital patients. Does that make sense? Now, this microorganism is actually quite important. So the star, the asterisk, shows that there is a vaccine against this infection. It's Crenibacterium diphtheria, causative agent of, well, diphtheria. This is one of the pathogens for which I want you to know the main virulence factor, which is exotoxin. Diphtheria exotoxin inhibits protein translation, leading to the cell death. So diphtheria is respiratory transmitted. It's quite contagious. As far as I remember, its basic reproduction number is between 5 and 7, which is a lot. So it infects epithelial cells of the upper respiratory tract and releases the toxin, which then causes the cell death. So epithelial cells start to die. That leads to inflammation and infiltration of white blood cells, which further promote the tissue injury. Accumulation of the dead cell, dead white blood cells, dead bacterial cells, dead epithelial cells, may lead to the formation of so-called pseudomembrane, and pseudomembrane can grow so large that it can obstruct the respiratory passages, leading to basically suffocation and death. Diphtheria is a life-threatening disease, and we do have a vaccine against it, which is called DTaP. Okay. Now, one of the best examples what happens when you stop vaccinating against diphtheria was demonstrated back in the late 80s in Soviet Union. So when everybody realized that Soviet Union was about to kind of collapse and government grip on day-to-day life was a bit released, people started to refuse vaccinating their children. And I must say, DTaP vaccine is pretty reactogenic. Okay, so kids have fever, headaches, whatever. So parents stopped vaccinating their kids. That same year, there was a massive diphtheria epidemic outbreak over the entire country. And I still remember, I was in the middle school. We had nurses. I mean, the grip was released, but just partially. So we had nurses coming over to school, administering DTaP vaccine, without even looking if we had it or not. Like, everybody's getting it. Side effects? What side effects? What you talking about? So, several thousand people died. You know, a lot of people got sick just because they stopped vaccinating. The disease returned in 1 year. Actinomyces is a member of the human microbiome, mostly oral microbiome, which can cause anaerobic infection. Yes, you thought it right. It can cause anaerobic infection after the human bite. Okay? Not only this, you know, it can be a post-surgical infection. Here you can see the consequence of the tissue infection with actinomyces called a lumpy jaw. Another common disease associated with actinomyces infection in the hospital settings is endocarditis caused by actinomyces israeli. Now, Gardnerella vaginalis, shown here, this cocci, causes the condition vaginitis and vaginosis. The condition is called Gardnerellosis, and it's still really unclear if Gardnerella is a single causative agent that leads to vaginosis, or if it is a bystander. What do I mean by that? So it is known that Gardnerella vaginalis can be found in the microbiome, in the healthy vaginal microbiome, you know, without any signs or symptoms of disease. Does that make sense? Now, treatment with antibiotics often leads to the disruption of microbiome. Gardnerella starts to replicate, and at the same time, vaginosis ensues. So the question is, does it happen, does vaginosis happen because of the Gardnerella infection, or Gardnerella nothing more than an innocent bystander just showing that there is some kind of abnormality in the vaginal microbiome? We have no answer yet. We don't know. Okay? Does that make sense? Now, these microorganisms, Enterococci, Propionibacterium, and MYCOCOCCI, I put them all together, although they belong to different taxa of gram-positive microorganisms. I put them all together because they represent normal human microorganisms found in different locations of the body. We're going to start with Enterococcus, Enterococcus faecalis, which is a normal component of the human gut microbiome. Does that make sense? So the statement, by the way, both should be all these microbes are commensal bacteria. So Enterococcus faecalis is found in gastrointestinal tract. Propionibacterium and MYCOCOCCI found in the skin. So why we are so concerned about Enterococcus faecalis? It turns out that this microorganism acquired quite a lot of resistance to antibiotic vancomycin, because we used vancomycin to treat patients with methicillin resistance to Staphylococcus aureus. So Enterococcus in those patients' guts was constantly exposed to vancomycin and eventually developed the resistance. Does that make sense? Then those same patients that were treated, they started to shed vancomycin-resistant Enterococcus. It ended up being in the hospital environment, and when it's transmitted to other folks, it can cause a variety of infections in the sterile sites again, such as endocarditis, meningitis, or urinary tract infection. Now, Propionibacterium acnes is a microorganism that normally inhabits hair follicles. Not so much skin, but hair follicles. This microorganism feeds on fat that we produce in the form of sebum, the secretion of a sebaceous gland. Does that make sense? The secretion that makes our skin oily. So when kids enter puberty, the sebaceous glands start to produce much more sebum. Okay? So sebum production leads to the overgrowth of the Propionibacterium acnes, which may in turn lead to acne, inflammation of the hair follicles. It is treatable. It can be treated topically or orally, specifically doxycycline. It's entirely human microbiome component. It doesn't cause, to my knowledge, anything except acne. Okay? Now, Mycococcus is one of the, honestly, most benign microorganisms that we're talking about. It's a skin microbiome component. That's the microorganism that gives unpleasant odor to clothing when you wear it for a while. Okay, because it metabolizes components of the sweat. Now, it was shown to cause infections in patients with HIV/AIDS. But you can imagine that in patients with HIV/AIDS, virtually any microorganism can cause an infection. Now, these microorganisms, Mycoplasma, formerly belonged to gram-positive bacteria. However, they also are often classified as molecules. Molecules means no cell wall. Okay? You can ask, what's the name for microorganisms with a cell wall? It's firmicutes. Okay. So Mycoplasma are the cells without cell wall, meaning that they are pleiotropic. They have no defined shape. You cannot say that they're cocci or bacilli or spirochetes. Does that make sense? So two members of the Mycoplasma genus represent the clinical interest for us. One is Mycoplasma pneumonia, shown here. See filamentous Mycoplasma pneumonia and completely differently shaped Mycoplasma cells bound to mucosa, ciliated mucosa. So Mycoplasma pneumonia is the causative agent, so-called walking pneumonia. I believe you are familiar with that condition. It's probably the mildest of all, and it's treatable. The very standard treatment for walking pneumonia is azithromycin. You cannot use any inhibitors of the cell wall synthesis on these microorganisms because they have no cell wall. Another member of that same genus is Mycoplasma genitalium. It's a sexually transmitted infection that causes, mycoplasmosis, and I'm gonna introduce the usual complications of an STD. So in the males, what happens when a male gets an STD? It starts with inflammation of urethra, called urethritis. Then it can lead to so-called dysuria. Then it can migrate into the urinary bladder, causing cystitis. Then it can migrate from the urinary bladder to the kidneys, causing glomerulonephritis. This is like really, really, really neglected infection if the patient does not take care of it. In females, the story is slightly different. So sexually transmitted infection will enter through the vagina into the uterus and may lead to the developing of endometritis, okay, endometriosis. And if this is left untreated, that it will go into the fallopian tubes, causing salpingitis, inflammation of fallopian tubes. If this is not taken care of, your immune system will lead to the resolution of inflammation in fallopian tubes, and the scar tissue will be formed. Now, in the meantime, microorganism keeps migrating, spreading through fallopian tubes, and then it has a chance to enter the pelvic cavity. Because as you remember, fallopian tubes open into a pelvic cavity. There is no direct connection between the ovaries and the fallopian tubes, right? So when microorganism enters the pelvic cavity, this leads to what's called pelvic inflammatory disease. Okay. So the main problem, of course, with all sexually transmitted infections is that they often are asymptomatic or minimally symptomatic. So by the time the severe symptoms occur, like endometriosis or pelvic inflammatory disease, this time, the damage, extensive damage is done. Now that brings us to the last unserved members of gram-positive microorganisms. Bifidobacteria, the left lactobacilli in the center, and leuconostoc on the right. Those are probiotic microorganisms. Okay, and I'm going to mention only these 3 gram-positive probiotics. There are some gram-negative ones, but here we're going to talk only about gram-positive probiotics. So basically, bifidobacteria and lactobacilli are 2 most common fermenting microorganisms found in various fermented foods, from buttermilk and yogurt to sauerkraut and beer and kimchi. Okay. Now, interestingly enough, both bifidobacteria and lactobacilli are found in the human microbiome. Bifidobacteria and lactobacilli, bifidobacteria more than lactobacilli, are found in intestinal microbiome, and lactobacilli are the main taxa of vaginal microbiome. Now, multiple studies demonstrated that consumption of fermented foods, all the ones that we listed before, mentioned before, actually has a positive effect on the variety of human ailments, from ulcerative colitis to common cold, Crohn's disease. Okay. So now, more and more, food that contains probiotic bacteria is included into a therapeutic regimen for people, especially with inflammatory bowel syndrome. Does that make sense? Yes.
What about supplements, probiotic supplements?
Oh, they're great. No, they're totally fine. I mentioned when we talked about the microbiome, Lactobacillus reuteri was shown to ameliorate symptoms of autism in the mouse model just by itself, and you can buy this Lactobacillus as the food supplement. It's like $8 a can, and it's definitely not going to make anything worse. I just think, if there is an option between just popping pills or actually eating some pretty good food, yeah, I would always go for food, but personally. But yeah, there's a lot of rather small clinical studies when patients with certain diseases are given, probiotic foods, and they do much better. It doesn't cure, but they do much better. There was allegedly the case of curing tuberculosis in a woman by, she was drinking basically like a buttermilk for an extended period of time, and all those cultures probably modulated her immune response, and she cleared the infection. So yeah, it's good. You can take supplements, but food's good too.
Is there like do you take them?
No, I like kimchi. I like yogurts. I eat food, fermented food, but absolutely, that's part of my personal diet. Yep. Now, Leucana stock is also used in the food production, but the interesting part is that you can find actually cases of nosocomial infection with Leucana stock. Imagine getting sick from buttermilk. That sounds kind of, pretty bad. But that's in people who are severely immunodeficient. Terribly immunodeficient. Now that brings us to, well, if you would ask, there are two opinions about which microorganisms, which bacteria are more interesting. Some people say that, gram-negative microorganisms are more interesting, and other people just wrong. So we're going to talk about the most interesting microorganisms, the gram-negatives, the ones that cause really serious and fascinating clinical diseases. We're going to start with the Bartonella, Bartonella henselae, and Bartonella quintana. So Bartonella henselae, shown here in the image, flagellated gram-negative bacillus, causes cat scratch fever. Picture is shown right here. Okay. So quite obviously it can be acquired from a cat scratch. Yes, from the cat. But not only from the cat, it can be transmitted by fleas, it can be transmitted by ticks. It's absolutely treatable. In many cases it is self-limiting and does not require any treatment. But in patients who are immunocompromised, it may lead to hepatitis. Okay. Bartonella quintana is an infection transmitted by lice. That's the human louse. Here, there are three types of lice. There's a type of lice that is a head louse, body louse, and the pubic louse. Fun fact, in French, the name for the pubic louse is papillon d'amour, which means the butterfly of love. So the lice that transmit Bartonella quintana are body lice, and the infection causes, the microorganism causes an infection known as trench fever. This infection was first identified in World War I, when people who were cramped in the trenches, the front lines, got this infection pretty common. So in healthy people, this infection is also self-limiting mainly, okay? But obviously in the folks that were malnourished and tired and stressed back in 1915, this infection could actually be very serious and may lead to a lethal outcome. And I want to remind you, no antibiotics at that time. Now the third one that I wanted to mention is Brucella abortus. So it's a zoonotic disease. It's acquired via close contact with cattle. It can be acquired by milk, by indirect route, and it causes what's called brucellosis, or undulant fever, or Banks fever, or Maltese fever. All those names mean that same disease. It's called undulant fever because during the course of infection, body temperature of the patient changes, going high-low, high-low. This infection is treatable, but it can become chronic, and it may lead to the infections of the bones and joints. Now, brucellosis is a really big problem in developing countries. It's pretty common in cattle there, and it is considered to be more important veterinary than human pathogen, because as you can guess from the name of that microorganism, Brucella abortus, causes spontaneous abortions in cattle, and that's, a huge veterinarian problem. Now these three, Rickettsia, Coxiella, and Ehrlichia, are all intracellular infections. And we're going to start with the Rickettsia. You can see small hemolymph cell of a tick with a number of rickettsial pathogens inside. So those red tiny dots are Rickettsia. There are many species in the genus Rickettsia that can cause a variety of human infections. One that is most famous is Rickettsia rickettsii, causes Rocky Mountain spotted fever. Rickettsia cari causes rickettsial pox. Provazieki causes typhus. Now they all have something very similar between them. First, they all are obligate intracellular parasites. Rickettsia cannot reproduce outside of the cell. You cannot grow it on the agar plate. Does that make sense? You see what I'm trying to say? It has to reproduce in the cell. Second common feature, they all are transmitted by vectors. It can be ticks, it can be mites or chiggers, or it can be lice. For instance, Rickettsia provazieki, that causes typhus, is transmitted by lice. Rickettsia rickettsii is transmitted by ticks. Now, Rocky Mountain spotted fever and, a variety of other rickettsial infections, they all characterized usually by rash. Okay, so this is a typical rash in a patient with Rocky Mountain spotted fever. It's a pretty serious disease, which surprisingly isn't found in the Rocky Mountain region. It was identified by the Rocky Mountain labs in Montana, but this infection is common in Tennessee, Missouri, Arkansas, Kentucky, really forested areas where the ticks come. That makes sense? Now, Coxiella burnetii, spore-forming gram-negative microorganism, shown here. Okay, so this is an endospore, and that's reproducing cell with 2 nucleoids. Coxiella burnetii for a very long time was considered to be a obligate intracellular pathogen. As it was shown in about 2006, it is not obligate intracellular pathogen. So in people, in animals, it does grow in the cell. But one really stubborn graduate student actually demonstrated that you can grow Coxiella burnetii outside of the cell. It causes Q fever, BSL-3 disease, that, just bad fever. Basically, all these infections that we're talking about right now, Bartonella, BRUCELLA, Coxiella, Rickettsia, they all cause what often is referred to as bacterial non-hemorrhagic fevers. Because symptoms are pretty similar. You have fever, you have headache, muscle ache, joint ache, and sometimes rash. Does that make sense? So Rocky Mountain spotted fever has pretty high mortality. Q fever has lower mortality. Transmission is zoonotic, either by inhalation or by the consumption of infected meat. And the third microorganism that I wanted to mention, a couple of species of Ehrlichia. So Ehrlichia chiefensis and Ehrlichia phagocytophila infect white blood cells. Ehrlichia chiefensis infects monocytes, phagocytophil, and neutrophils. Transmitted by ticks, such as Lone Star tick. And again, the symptoms are the same. Now, why pay attention to specifically Ehrlichia? Cases of ehrlichiosis but pretty common in Ohio, Pennsylvania, and New England in general, because the tick is found here. Does that make sense? Which brings us to a interesting intracellular, obligate intracellular pathogen, Chlamydia trachomatis. So, Chlamydia trachomatis, I need to correct this slide finally. It is not most common sexually transmitted disease in the United States anymore. Human papillomavirus took over. Chlamydia takes the second place. It's the second most commonly sexually transmitted disease in the US. Now, I mentioned that this infection is intracellular, obligate intracellular, which doesn't mean that chlamydia will die immediately when it's outside of the cell. In fact, here you can see chlamydial cells outside of the vaginal epithelium. So it can survive, it just cannot reproduce. In order to reproduce, it has to infect the cell, where it will produce elementary bodies, which then infect other cells. Does that make sense? So, in order to reproduce, chlamydia has to infect the cell. Now, the most common infection associated with chlamydia, as we all know, is vaginal or penile chlamydiasis. Okay? All the same story as with Mycoplasma genitalium. If infection is left untreated, it may lead to inflammation of the urinary bladder, cystitis, or if it spreads through the female reproductive tract, it may lead to the inflammation of, uterus and fallopian tubes and so on and so forth. Very common symptom of the chronic chlamydia infection is lymphogranuloma venereum. So, swollen inguinal lymph nodes are swollen because of the chlamydial infection of the lymph nodes. But generally speaking, in the chronic STDs, inflammation of the inguinal lymph nodes and enlargement of inguinal lymph nodes is pretty common. Okay. Now, another condition associated with chlamydia infection is trachoma, conjunctivitis. So it's pretty common. It can be congenital. It can happen in adults. So it requires a transmission from the reproductive mucosa to the eye mucosa. In adults, it has to be basically a voluntary transmission, so somebody has to touch their private parts and then touch their eyes without washing their hands. In children, trachoma is usually acquired during the birth, via birth canal. So if mother is unaware of the ongoing chlamydial infection, microorganisms may end up on the conjunctiva of an eye and cause inflammation and formation of so-called pseudomembrane. So this picture shows you the image of pretty advanced trachoma, and this is conjunctiva of an infected child with a so-called typical cobblestone appearance. If conjunctiva is left untreated, it ultimately leads to the loss of vision. It is very treatable with antibiotics. Tetracycline takes care of it. Tetracycline is basically a first choice antibiotic for any intracellular infection. Now, interesting thing is, trachoma is very common in developing countries, especially in Africa. And I had a privilege to work with a person who was a part of the project to develop a vaccine against trachoma. And they basically made it, but it never made it to the market because antibiotics are fairly inexpensive. But she mentioned that chlamydia trachomatis, when you work with it in the lab settings, is extremely infectious, super contagious. And she said that the entire group that was working on the vaccine, the entire group had trachoma. I mean, they had eye infection, they got treated, everything's fine, but it's just, it's so transmissible There was no way to avoid it. Bordetella and NEISSERIA. So, if you don't mind, I'm going to start with NEISSERIA because I want to share something with Bordetella. Two members of the same genus causing completely different diseases. NEISSERIA meningitidis, shown here, growing on the chocolate agar, is a gram-negative coccus, aerobic gram-negative coccus, also known as meningococcus, causing meningitis. It is one of the three main causes of community-acquired meningitis, along with Streptococcus pneumonia, and Haemophilus influenza, which we're going to talk about a bit later. So, it's a respiratory transmitted infection. And it's a shame because it looks like Neisseria meningitidis is an entirely human bacteria. So if we would be able to vaccinate each and every person in the world against Neisseria and do it consistently over, maybe a dozen years, we would be able to eliminate this infection. And this is the most serious type of meningitis. There were reports of lab-acquired Neisseria infection when, the lab workers opened the agar plate with Neisseria not under the biosafety hood, got exposed to minimal doses of meningococcus, and succumbed to the infection 48 hours later. Because the respiratory route provides basically a patented way to the brain. That makes sense? Now this is totally vaccine-preventable disease. Also, that's one type of the disease when treatment starts before any diagnosis is made. You see what I'm saying? So when a patient comes in meningitis, for which the very typical symptom is a headache, confusion, and stiff neck, then treatment is started right away, and then doctors will determine what's going on. Now, for Neisseria meningitidis infection, a distinctive feature is petechia on the limbs. So Neisseria meningitidis leads to the coagulation issues, basically thrombocytopenia. Make sense? And that thrombocytopenia leads to these minor bleedings in the skin that we call petechia. Sort of a clinical feature, allows you to distinguish meningococcal meningitis from other meningitis. Neisseria gonorrhea is sexually transmitted disease that leads to a variety of symptoms and signs in males and females. Here you can see the penile secretions in gonorrhea and those are vaginal ones. Usually in gonorrheal infections you can observe the pus in penile or vaginal secretions. It's very treatable with antibiotics. However, now more and more cases of antibiotic-resistant gonorrhea are observed in the United States. My personal attribution, people probably do not take all the antibiotics that they were prescribed, or they are too embarrassed to go to the doctor. And yes, you can illegally purchase the antibiotics without prescription. Nobody's going to prosecute you for that. So they probably do that, take them not in the way they're supposed to. They treat the infection, but that leads to the development of antibiotic-resistant strains. Now, just as with chlamydia, there is a conjunctivitis associated with the transmission of Neisseria gonorrhea from mother to child. When a kid passes through the birth canal, an infected mother, that can get on the conjunctiva, and we call it ophthalmia neonatorum. If you're curious, can this happen in adult? The answer is yes. There were reports of self-inoculation. pretty stupid setting. The gentleman thought that washing his eyes with urine will help to cure his short-sightedness. It's a pretty common hoax, you know, using urine as the therapeutic approach, let's put it this way. So that gentleman used his urine to wash his eyes and transmitted gonorrhea onto conjunctiva and eventually went blind. Anyway, that brings us to Bordetella. That's the causative agent. Bordetella pertussis. It's the causative agent of whooping cough. Okay. The clinical course of infection is fascinating. Upon the infection with Bordetella, okay, the susceptible person will eventually develop catarrhal symptoms. It's called a catarrhal stage, meaning that the person will have symptoms of a pretty typical common cold. You know, runny nose, mild cough, and sneezing. During that time, microorganism actively replicates in a pseudostratified ciliated epithelium of the lower respiratory tract, such as trachea and bronchi. During the replication, the toxin of Bordetella will lead to the destruction of the epithelium. And that leads to accumulation of mucus in the lower respiratory tract. Accumulated mucus, you know, leads to the attempt to cough it out. Fairly unsuccessful attempts. And that's what causes the whooping cough. This is called paroxysmal stage. And what needs to be highlighted that during paroxysmal stage, the microorganism is largely gone. So treatment of a patient with a clinical whooping cough with antibiotics is very limited efficiency, because the main problem is the lack of ciliated epithelium, not the infection itself. So treatment during paroxysms is mainly supportive, vasodilators, mucolytics. The cough can be so violent that it may lead to vomiting and bloodshot eyes. So violent cough leads to the rupture of the blood vessels in the eye. Okay. Now, adults will recover from that condition, and in the third or convalescent stage, paroxysms will become less and less frequent and less intense. Now, this infection is completely vaccine preventable. To give an idea how important it is to prevent this infection, here's the demonstration of what whooping cough sounds like. It takes a while. I think that's enough. So for people who do not vaccinate their children, you know, you can ask, do you think your child will be grateful if they will experience this? Because that's what's going to happen. Whooping cough is more abundant than we might think, and unvaccinated children are readily developing this condition. One of the reasons one of the reasons why vaccine is not super effective, it's about 75-80% seroconversion, meaning that out of, say, 5 people that get vaccinated, only 4 will actually get protective immunity. I mean, it's better than none, but still not great. Why is that so? Originally, when the vaccine against diphtheria, tetanus, and pertussis was introduced, It was called DTP, without A in the middle, which stood for diphtheria, tetanus, and pertussis. And this vaccine caused a massive side effects. Mainly very high fever and just general, like, not doing well for a couple of days. Considering that this vaccine was given to babies, okay, like 6-month babies, that was pretty concerning, the level of side effects. So scientists managed to identify what actually was causing all the side effects, and that was pertussis. And they realized that side effects are caused most likely by lipopolysaccharide, endotoxin, that was coming into the vaccine together with killed pertussis cells, Bordetella pertussis cells. Does that make sense? So they introduced the letter A. Well, speaking seriously, A stands for acellular. So they took a pertussis component and cleaned it. You see what I'm saying? They removed all the pathogens, lipopolysaccharide, and endotoxin thing, which made a vaccine much better in terms of the side effects, but it also made the vaccine less efficient for some reason. We don't really know the immunological mechanism behind it. So the original vaccine was pretty hardcore in terms of the side effects, but it was also more protective. Acellular pertussis vaccine is less protective. But, kids receive multiple booster shots, so overall, if you got your DTaP vaccination, you're fine. Now that brings us to conversation about some commensals. So we're going to talk about commensal Enterobacteriaceae and E. coli, and then we're going to take a break. So commensal means that these microorganisms can be found in a human gut. Well, can be found in a human, and Enterobacteriaceae means that they can be found in the gut. Are we clear? Cool. So obviously there are actually hundreds and hundreds of different species found in the gut microbiome. But I want to focus your attention on these 4 that can actually be pretty successful opportunistic pathogens. So Enterobacter aerogenes is the common member of the human gut microbiota, and it causes opportunistic pneumonia in the hospital settings. They all are nosocomial infections, okay? All commensal Enterobacteriaceae are nosocomial. Am I clear? Klebsiella, shown here, Klebsiella pneumonia, is the common cause of lobar pneumonia in the hospital patients, meaning that it can be respiratory transmitted. Okay? Proteus mirabilis is famous for urinary tract infections that it causes in patients in the hospital. And Serratia marcescens is the common cause of UTIs and wound infections. So what they all have in common? First, they found in the human gut. Second, they shed via fecal route. Third, they will most likely not affect immunocompetent healthy people, but in the patients in the hospital who are immunocompromised, they may cause a variety of infections. All of them can cause urinary tract infections, absolutely. And some, like Enterobacter and Klebsiella, cause pneumonia. Okay? Others, such as Serratia, can cause wound infections. Another pretty common thing among these 4 is that since they are present in the human gut and are constantly exposed to antibiotics, they develop a pretty broad range of antibiotic resistance. This is why in the treatment graph, the statement, treatment is guided by antibiotic susceptibility. Remember we did a lab when we checked the antibiotic resistance of various microorganisms? So that Kirby-Bauer disc diffusion test is done in the hospital as antibiogram. I don't remember if I mentioned it. No. So you have a team of scientists, well, a team of clinical microbiologists that will sample various surfaces in the hospital, and they will check which microorganisms they can cultivate from there. You see what I'm trying to say? What they can find in a hospital, what they can find on the toilet seats or doorknobs, or I don't know, IV poles. You see what I'm saying? So they will identify those microorganisms, and they will determine their sensitivity to antibiotics. So when the patient has, I don't know, UTI caused by Serratia, they know exactly what to use for treatment and what not to use because it's going to be inefficient. Okay, this is why I mentioned guided by antibiotic susceptibility. Now, E. coli kind of stands out. It can be categorized as the commensal Enterobacteriaceae, but in terms of the clinical significance, E. coli is much more important than those microorganisms that we just mentioned. So it's usually facultative anaerobic microorganism, can be fairly easily identified using EMB agar. It produces a characteristic green metallic growth on it. And E. coli comes in different shapes and forms. Well, not literally, but I'm talking about the clinical presentation. So those are different types of E. coli. Please do not memorize these acronyms, what they mean. I don't really focus on that too much. I want you to see a common symptom of intestinal E. coli infection. Diarrhea, 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 diarrhea. All different types of E. coli cause diarrhea. They damage intestinal epithelium, usually disrupting microvilli. Does that make sense? Disrupted microvilli cannot normally absorb water and sodium, and that lack of proper sodium and water absorption leaves the ions into the lumen of intestine, which leaves water in the lumen of intestine, which leads to the diarrhea. Does that make sense? Usually E. coli diarrhea is self-limiting. Okay? It can be treated by antibiotics. Now, one strain of E. coli, so-called enterohemorrhagic E. coli, stands out. Okay? So enterohemorrhagic E. coli, its transmission is associated with the foot. This graph shows you the transmission of enterohemorrhagic E. coli in the United States. It's a famous strain 0157H7. Enterohemorrhagic E. coli is transmitted mostly via food. Does that make sense? Not all food. The main food that EHEC is transmitted through is ground beef. Most likely it gets contaminated during processing in the butcher houses, and that's the main one. But we know that there were outbreaks recently associated with, say, romaine salad. And one of the most famous outbreaks in Germany in, I believe, 2008 was associated with the bean sprouts. Now I have to highlight, yes, those are outbreaks. But we're talking about the routine transmission, and routine transmission is through the undercooked ground beef. Can also be transmitted person to person. Read fecal oral. Unknown route. Waterborne. Contact with animals, and I really want to check what was that laboratory transmission in 2002. Somebody got a lot of stuff contaminated. Now, why are we so concerned about enterohemorrhagic E. coli? Unlike other strains of that microorganism, enterohemorrhagic E. coli contains shigatoxin. And shigatoxin inhibits translation and leads to the cell death. That leads to the full-blown destruction of intestinal epithelium, which leads to dysentery and hemolytic uremic syndrome. Meaning that if this microorganism gets in the blood, it starts to destroy red blood cells. And destruction of red blood cells, hemolysis, hemolytic component, leads to the kidney dysfunction. So urea starts to accumulate in the blood. So that's uremic component. Hemolytic uremic syndrome. This syndrome basically shows the kidney damage, and kidney damage can be so severe that may lead to a death of an infected patient. Another very characteristic infection that is caused by E. coli, just to know, so UTI, it's the main cause of urinary tract infection in humans. Okay? We're good? And along with Streptococcus agalactiae and Listeria monocytogenes, E. coli is one of 3 main causes of neonatal meningitis. So we're going to add Listeria and Streptococci. Does that make sense? Now, before we go to break, I will post the study guide on this chapter, but in general, things that you need to know and don't need to know, I will outline it for you now. So you do need to be able to put a name of the microorganism and the disease that it causes. Am I clear? Say I tell you, well, Corynebacterium diphtheria, well, diphtheria, right? Like Bordetella pertussis, whooping cough. Am I clear? You have to know whether or not there is a vaccine. You also have to know the route of transmission. Now, you don't need to know 99% of virulence factors, except for the ones that I have them on the list. I will publish them, I promise. There's like 7 virulence factors that I want you to know 5. Okay? Like, this toxin belongs to this microorganism and it does that. This toxin belongs to this microorganism and it does this. For instance, I mentioned Corynebacterium toxin, diphtheria toxin. Okay? Diphtheria toxin inhibits protein synthesis. This is as far as it goes. Am I clear? Yeah, I believe that's all. Okay, but most challenging thing, you must know gram-positive or gram-negative. This is something that sometimes, gets out of your attention, but you will get a question, something like, which of the gram-negative microorganisms causes meningitis? And you get a list, okay, in the answer. And I will put, to trick you, I will put both gram-negatives and gram-positives. And if you know your stuff, you look at it and say, okay, this is gram-positive, out. This is gram-positive, out. I have 2 gram-negatives left. Which of those causes meningitis? Does that make sense? Got it?